Please start, sir. We are live.
Good evening, everyone. I welcome you all for today's webinar on Oncology Frontier, Navigating Lung, Breast, GI, and GU Cancer. With immense pleasure, I would like to invite Dr. Priyanshu Chaudhary, who is Senior Consultant Medical Oncologist at Livasa Hospital, Mohali, for the welcome and introductory note. The stage is all yours, sir.
Thank you. Good evening to everybody. And I think we'll be continuing from where we left yesterday. And the first talk is by Dr. Arun Raja. And so I'll be welcoming Dr. Arun Raja for his first talk today. And over to you, Dr. Arun. And welcome again.
Thank you, sir. Thank you so much. So I believe I'm audible.
Yes, sir, you're audible.
The videos are clear. Okay. So good evening, Dr. Priyanshu. Thanks for inviting me. So in the second innings of the day, I'm just the opener to talk about the FLARA-2 trial. And I thank the Horizon Conference Committee and I thank AstraZeneca Institute, Rajneesh Mahajan for to be associated with us in the academic session. So I thanks once again. Please share the slide from your end.
Sir, are the slides visible?
The slides are visible. One second also. Not, your screen is minimized, it seems.
Okay,
Yes,
I will
yes.
reshare again.
No, visible, it's moving on.
Okay. Sure.
And please, just up and down, please move the slides. So once again, we'll check and I will go for a presentation. Okay. So today's a discussion regarding the FLARA-2 trial. So how we are going to reignite and reimagine the mutation positive cases, EGFR mutation positive cases in advanced lung cancer with combination therapies. Next slide, please. So this is the introduction slide. So we all know that EGFR mutation is roughly around 40-20% in Asian and non-Asian population. Incidence in India is around 33 to 39 roughly. It syncs with the Asian population 40%. The most common mutation is exon 19 deletion and exon 21 point mutation, L858R mutation. Next slide. So what is the recent outcomes with what's the performance of the TKS in EGFR mutation status? If you see that from the median PFS jumping from 9.5 to 18.9 from the first generation, second generation, and third generation TKS. It means that the PFS is prolonged with the use of third generation TKS. Next slide. The only significant overall survival benefit was with osimertinib with a significant p-value. So if you can see in the graph, it means that from Jeffrey 22%, we gained up to 38.6, roughly 40 months. It means that we are surpassing 3 years with the third generation TKS in advanced non-small cell lung cancer. Next slide. Even then, we are not happy because there is the loss of EGFR T mutation. What to say? The mutation T79 is present in roughly half of the patient, and multiple resistant mechanisms comes along the treatment therapy. Then again we have acquired resistance due to TKS. That's a significant challenge in long-term clinical response. So the solution is to combine with the chemo with the TKA. So this strategy has evolved to avoid or delay or to prolong the emergence of acquired resistance to TKA with intent to improve the clinical outcomes. Next slide. So what the combination did, why we need this combination? Because the rationale is very few patients remain on therapy after 2 years. So there is an unmet need to improve the outcomes in EGFR mutation positive cases. Very few patients has a very good 5 overall survival rate, highlighting the heterogeneity of the disease. Next slide. So the proof of principle is here is if you combine chemotherapy with the TKA, you will get a good response. So if you could see the overall response rate, PFS and OS are improved with the combination. Next slide. This is a famous TMH study. So it showed that there is improvement in PFS and OS with the use of gefitinib, pemetrexed, and carboplatin in mutated lung cancer. Next slide. So NEJ09 study is again is the same more or less a success story with the combination therapy. So it prolonged the PFS, it prolonged the overall survival, although it has some significant toxicity. Next slide. So again, the preclinical evidence showed that chemotherapy drugs can enter brain in brain metastasis patient. So you all know that brain metastasis means there is a disruption of blood-brain barrier. So the barrier is broken, the chemotherapeutic drugs can reach there. So with this principle, the combination therapy has been explored. Next slide. So even the chemotherapy has a response in the brain mets in the lung cancer patients. So if you see with the doublets with platinum, it's more or less 23. Sometimes it happens around 45 months. If you use the pemetrexed, the response rates are better. Next slide. Next slide, ma'am, please. Move on. So again, the GAP brain trial, it showed that with the combination of gefitinib with chemotherapy, there is a early separation of GAP. Again, the significant improvement in the intracranial PFS with the hazard ratio of 0.36. Next slide. So again, the PFS and OR improved as compared to gefitinib alone. Next slide. This is the famous FLARA-2 trial, which had the standing ovation in the World Lung Conference in 2023. So this trial is interesting trial. It has two phases: the safety run-in period, followed by the randomization. Randomization. So here the inclusion criteria is pretty much straightforward. Pathologically confirmed non-squamous small cell EGFR mutated cases with a reasonable performance status, with no prior systemic therapy, stable CNS meds are allowed, brain scan was done at baseline. So what the trial did is they combined osimertinib with pemetrexed and carboplatin or cisplatin for 4 cycles, followed by maintenance pemi plus osimertinib. There is a 1:1 randomization. So the primary endpoint was PFS. It was assessed by investigator and central review. The second endpoint was overall survival, overall response rate, intracranial response, safety profile, and PFS2. Next slide. If you see the baseline curve, they eventually match. What is important for us is adenocarcinoma, adenosquamous was included, EGFR mutation, common mutation was included, extrathoracic disease was evenly matched, CNS mets were 40% at baseline in both. Next slide. So after the study, what they found out, there is an early separation of GRAF. It was found out by the investigator. They found out that the median PFS was 25.5 months versus 16.7 months. The benefit was around roughly 9 months. Next slide. Again, the central review, what they found out was even better response with a proper investigation. They found out that the PFS increased closely to 9.5 months, so roughly 10 months. So jumping from 8 to 9.5 months is a great thing. Next slide. Even what they found out, they dissected the subgroup, which is important in clinical practices. If you see the CNS status as the baseline. They responded beautifully. Then EGFR mutation patients, they responded beautifully. So it means that even we know that osimertinib is a wonderful drug. In a single agent, it works very nicely, very nice in stage 4 patient. With the combination of chemotherapy, it works even better. Next slide. The treatment for what to say, it's a first line therapy and second line therapy, subsequent therapy. So if you see that in first line, it was 0.73 hazard ratio. Even for subsequent therapy, even then hazard ratio was 0.69. Next slide. So what is the next most common first line subsequent therapy? Eventually, the chemotherapy was given for all patients. Next slide. So what happened? Osimertinib with chemotherapy even reduced the PFS2 by 30%. It means that it respond beautifully in the later lines also. Next slide. Second interim analysis, overall survival in stage 4 disease. Very few drugs are able to demonstrate the clinical benefit. One of the drugs is osimertinib. Even with chemotherapy, it scored very well. Even the data is mature enough to comment that the overall survival is better with osimertinib along with chemotherapy. Next slide, please. Tumor response rate is Here you could see that objective response rate is 83% versus 76. Even the partial response are higher. The median duration of response, it means that 2 years that is sustained response. Next slide. What happened to the CNS mets at the baseline? They found out there is a early separation of curve. Even the PFS was 24 months. It is 2 years as compared to 1 year. So the hazard ratio was 0.47. Next slide, please. Even in CNS PFS, they analyze two things. One is available for response set and full analysis set. If you see that in both pays, hazard ratio is beneficial only 0.58 versus 0.40. Next slide. Here, again, to re-emphasize that CNS overall response rate is better with the combination. Next slide. Again, the another indirect evidence is the combination also decrease the risk of CNS progression. We have a response, we have a decreased CNS progression. It means that there is probability that CNS progression at 24 months is 9% in the chemotherapy with osimertinib arm rather than 23% with monotherapy arm. It means that we have a gross difference of 14%. Next slide, please. We all know the chemotherapy side effects will be there. Anemia, thrombocytopenia, neutropenia will be there with the combination. There is a peculiar side effect of osimertinib is diarrhea. Diarrhea is commonly reported. Other than this regime is pretty tolerable in the routine clinical practice. Next slide. Regarding the safety summary, what is important here is the frequent discontinuation due to side effects. Any grade of third, that is 64% because we know that the toxicity will be there. Even then, if you focus on the median duration of response, it is 24 months versus 20 months in the osimertinib monotherapy arm. So here the combination received only 4 cycles followed by 12 cycles of median 12 cycles of pembrolizumab. Many patients received up to 48 cycles also. Next slide, please. Then selected adverse effect of clinical interest is, so if you leave about the GIT toxicity, the febrile neutropenia is very less, and the intestinal pneumonitis is very less. It is there, but it's very less than 4%, less than 3%. That's it. Next slide. So what happens? There is the frequent toxicity during the induction period. It means that the patient will have a toxicity over the period of time. It vanishes. It means that the onset and severity is highest during the induction and gradually reduced over the time. So once the patient tolerability increases, the disease burden decreases, the regime is pretty much manageable in the clinical practice. Next slide. To summarize, if I want to choose whether to FLORA or FLORA 2, I choose only FLORA 2 because the EGFR TK has been standard. We all know that the combination is going to offer a new first line for the advanced disease patient. Even the combination it's improving the PFS. Even with the brain mets, the combination does not have any new adverse effect. Additionally, we all as a medical oncologist, we need to manage the toxicity profile of chemotherapy approach. So this is represent a new standard of care in the advanced non-small cell carcinoma in EGFR mutation positive cases. Once again, thank you for the organizers and thank you for Dr. Priyanshu personally. Thanks for AstraZeneca team.
Thank you, Dr. Arun. And if there are any questions, we'd like to welcome. So have you started using, Dr. Arun?
Yes, sir. Just I started only for first patient.
Okay.
With brain mets. After 2 cycles, I initiated it.
Okay, great. Shall we can proceed further then?
Yeah. So for our next talk, I would like to invite Dr. Chitresh Agrawal. He is senior consultant at Paras Hospital from Panchkula. Sir, the stage is all yours, please.
Thank you, Dr. Priyanshu. My slides are visible?
Yes, sir.
So the slide set has been, given, and all these are tongue twisters. So I will just go through the slides. It is the first evidence is for semilipimab monotherapy for first-line advanced non-small cell lung cancer patients with PD-L1 expression more than 50%. So this was the 5-year outcome of Empower Lung 1 study. So the key eligibility criteria was treatment-naive advanced non-small cell lung cancer patients who had PD-L1 expression of more than 50%. No driver mutation was there. And the patients were randomized to semilipimab monotherapy 350 milligrams Q3 weekly, or 4 to 6 cycles of investigator choice of chemotherapy. And this was continued till progression of disease. And then there was a crossover which was allowed on progression on the patients who were on chemotherapy arm. Now, what the results showed that there is a continuous benefit at the end of 5 years also. If we see in the overall survival, it is a 5-year analysis of 26.1 months versus 13.3 months. And the PFS was 8.1 months versus 5.3 months. And there was a high response rate also, with overall response rates being 46% versus 20.6%. And in the intention to treat population also, there is a benefit with the overall response rates being 42.3% versus 21.1%. So semiplimab benefits in OS and objective response rates, and it increases with the PD-L1 expression. So with addition of chemotherapy beyond disease progression, so patients, after addition of chemotherapy beyond progression, obtain optional continuation of semiplimab until progression plus 4 cycles of chemotherapy beyond progressive analysis. Here also, this shows that after the chemotherapy is added, the overall response rate is 28% and the median PFS is 6.5 months. And the overall survival is also 15.1 months. So this is the semilipimab plus chemotherapy versus chemotherapy alone in non-small cell lung cancer with PD-L1% more than 1%. So this is the subgroup analysis from Empower Lung 3 Part 2 trial. And here also we would be seeing that there was an improved efficacy of the combination over chemotherapy alone in both squamous and non-squamous histology. So, probability of PFS and OS, you can see both. There is a marked difference in early separation of curves when semilipimab was added to chemotherapy, and it had a great advantage. So this is the phase 3 study of ivonescimab versus pembrolizumab as first-line treatment for PD-L1 positive advanced non-small cell lung cancer. This is the Harmony 2 trial. So this is a phase 2 Harmony 2 trial where the
The comparators are ivonescimab versus pembrolizumab, and the median PFS was 11.14 months with ivonescimab, whereas with pembrolizumab it was 5.82 months, and the hazard ratio was 0.51, and the p-value was statistically found to be significant. Now, if we see the side effect profile, the difference in AIs were predominantly proteinuria, hypertension, and laboratory abnormalities. And we can see that proteinuria was higher with the usage of ivonescimab, and aspartate ALT AST increase was also high, and hypercholesterolemia was also high, and the salt was high in comparison to the pembrolizumab, where all these side effects were not as high as with the use of ivonescimab. So coming over to the antibody drug conjugates, we have sacituzumab tirumotecan in combination with KL-A167 as first-line treatment for patients with advanced non-small cell lung cancer. And this is from the phase 3 to OptiTrop Lung 01 study. Here, key eligibility criteria was locally recurrent or metastatic non-small cell lung cancer, no actionable genomic alteration. Cohort 1, the sacituzumab versus plus KL-167. The doses were different. Cohort 1B received KL-A167 at 900 milligram dose, and in the first cohort it was 1200 milligram dose Q3 weekly. And this was continued until progression or unacceptable toxicity. And the primary endpoint was ORR, and the secondary endpoints were DCR, DOR, PFS, and OS. Now in cohort 1A, the median follow-up was, overall response rates was 48.6%. And in cohort B, it was 77.6%. And the median PFS was not reached. So depending on the PD-L1 expression, in TPS less than 1%, overall response rate was 63.2%. In TPS 1 to 49, it was 81.3%. And in TPS more than 50%, it was 87%. And it was found to be more effective in the squamous histology, because in the squamous histology, the overall response rates were 84% in comparison to 72.7% in the non-squamous histology. If we see the PFS, 6-month PFS rate, here also we will see that the PFS improves with the increase of the PD-L1 expression. So in general, grade 3 hematological adverse events were more frequently observed. ILD occurred in one patient, and most common adverse events were rash, ALT increase, and AST increase, which were consistent with the known safety profile of KL-A167. Now moving on to the phase 3 trial of the similar molecule. It was previously untreated histologically or cytologically confirmed stage 4 squamous or non-squamous non-small cell lung cancer, PD-L1 expression of more than 50%, and it was again a comparison with pembrolizumab, and this was the results where secondary endpoint and primary endpoint. I think one slide is missing here, so I don't know what is the result of this trial. This is ongoing or this is yet to be reported. So moving on to datopotamab deruxtecan versus docetaxel in patients with non-small cell lung cancer. This is the final overall survival from TROPINE Lung 01 trial. And here in comparison to docetaxel, the molecule had a median overall survival of 12.9 months versus 11.8 months, and hazard ratio was 0.94. And if you see the squamous and non-squamous histology, you will see that non-squamous histology actually benefited with the drug that was in question. So this is the normalized membrane ratio of TROP2 by quantitative continuous scoring. Is it predictive of clinical outcomes in TROPINE Lung 1 trial? And measuring TROP2 normalized NMR use ratio using quantitative continuous scoring. So QCS is a novel, fully supervised computational pathology that precisely quantifies and locates targets like TROP2. So we can do by IHC, then we do the automatic image analysis, and patient biomarker status determination is done on more than equal to 75% of tumor cells which were TROP2 positive. And it differentiates tumor from non-tumor. And then we calculate the TROP2 NMR by membrane OD divided by membrane OD plus cytoplasmic OD. So these are the various methods, and based on this, we have to see what is the prevalence. Prevalence in non-squamous and squamous. In non-squamous, the prevalence is high. and it is close to 66%, whereas in squamous histology, it is around 44%. So NMR predicts the longer PFS with the drug data because we see here that with overall response rates, it was 32.7%, median PFS is 6.9%, and this is higher than what we see with the comparator arm, that is docetaxel. So in the non-actionable genomic alteration non-squamous group, the PFS again was better in comparison to docetaxel. Thank you.
Thank you, Dr. Chitresh.
Thank you. Thank you, Dr. Priyanshu.
Surangi, can you invite
Yeah.
the next one?
Yeah. So for the next talk, I would like to invite Dr. Priyanshu Chaudhary, Senior Consultant in Medical Oncology at Livasa Hospital, Morley.
Is my slide visible?
Yeah, sir. Just make it full screen.
Just a second. Just a second. So good evening, everyone. I'll be discussing the integration of immunotherapy into limited stage small cell lung cancer management. This session is sponsored by Astra. So lung cancer is the leading cause of cancer-related death worldwide. Small cell lung cancer represents 15% of all lung cancer cases. Lung cancer is categorized into two main types. We all know non-small cell lung cancer is the most common, around 85%, and the rest 15% are small cell lung cancer. Out of the small cell, around 25 are limited stage, and the rest are extensive stage. The median age at presentation is around 60 years of age, and the brain metastases occur at 50% of the patient with small cell lung cancer and are associated with poor outcomes. Small cell lung cancer occurs almost exclusively in smoker, with around 97% of patients having a history of smoking. So this is an Indian data, a 12-year analysis from North India. Small cell lung cancer data of 361 patients. Again, around 27% limited stage and 73% extensive stage, similar to what we've seen in the West. Median age slightly less, 57 years. Smoking status in around 77%, and 65% were ECOG 0 to 1. And delayed referral was there in almost 1/3 of the patient. So with respect to management of limited stage SCLC, we have chemotherapy in 70% and CTRT in around 25%. So based on the stage, I think these are matching. Median PFS is around 169 days in limited stage, and median OS around 191 days. So now coming to the unmet need in limited stage SCLC. So treatment outcomes in a limited stage SCLC remain poor. There is a high unmet need to improve survival outcome. The median OS ranges between 25 to 32 months. Although some patients with limited stage SCLC have long-term survival, approximately 20% after CTRT, the overall cure rate remains low. Despite having an initial sensitivity to CTRT, the majority of the patient relapse within months of initial therapy. 30% of the patient with limited stage SCLC are alive at 5 years. So again, if we look at the recurrence, the thoracic recurrence approaches almost 60% by the end of 4 years, and the CNS recurrence approaches around 20% by the end of 4 years. So classification of SCLC, if we see, although NSCLC is staged using TNM classification, the Veterans Lung Study Group system is most commonly used to stage SCLC. The VAL-SG system classifies SCLC as either limited or extensive. Limited disease is the one which is confined to one hemothorax, with or without regional lymph node metastasis, and with or without a pleural effusion independent of cytology of the same site. It is often confined to an area that can be encompassed within a radiation port. Corresponds to stage 1 to 3B of the TNM classification. 1/3 of the cases are presentation present with the limited disease. While we look at the extensive disease, any disease that at sites beyond the definition of limited disease corresponds to stage 4, NET, NEN, and M1A, B, or C. So 2/3 of the cases at presentation are in an extensive disease. Tumor beyond the boundaries of limited disease include distant metastasis, malignant pericardial or pleural effusion, and contralateral, supraclavicular, and contralateral hilar involvement. So the disease classification is very important because it dictates the choice of treatment. Limited stage SCLC, if we have very early, probably stage 1 and 2, then according to TNM, then surgery is possible, followed by chemo plus radiation, followed by PCI. While most of the cases are not surgically amenable and they receive chemotherapy plus thoracic irradiation followed by prophylactic cranial irradiation. Extensive stage SCLC received immunotherapy along with chemotherapy, and if there is a response, then the immunotherapy part can be continued as maintenance, and PCI is optional in this cases. So current landscape of treatment and patient approach. So concurrent chemoradiotherapy in limited stage SCLC. Concurrent chemoradiotherapy with cisplatin plus etoposide is the preferred treatment option for patients with a good performance status. ECOG 0 to 2 is taken in the United States. Patient with a poor performance status can be considered for sequential chemoradiotherapy, although the benefit is not as good as concurrent chemoradiotherapy. Surgery followed by adjuvant chemotherapy or concurrent chemoradiotherapy is preferred for those eligible, but a very small minority of patients are actually eligible for surgery. There is currently no approved targeted therapy. Will be discussing that, and that is the immunotherapy. So chemoradiotherapy treatment regimens in limited stage SCLC in clinical practice. So the preferred regimen is cisplatin plus etoposide plus radiotherapy, started with cycle 1 or 2 of chemotherapy. Usually before the second cycle, we start radiotherapy. So the cisplatin can be used between the dose of 60 to 80 milligram per meter square on day 1. We usually use 75 mg per meter square. Along with etoposide, 100 to 120 milligram per meter square for 3 days. We usually use 100 milligram per meter square dosage. Other regimen include cisplatin 25 mg per meter square for 3 days and etoposide 100 milligram per meter square for again 3 days every 3 to 4 week cycle. Carboplatin can be used with AUC 5 to 6 on day 1 if cisplatin is not tolerated or contraindicated, like patient with renal dysfunction. The standard recommended radiotherapy regimen is 45 gray twice daily in 30 fraction, but in practice, the single dose regimen is more widely used because of logistics issue. The dose and fractionation differ in various countries. Treatment can be heterogeneous. Concurrent chemoradiotherapy is preferred over sequential chemoradiotherapy. Sequential chemoradiotherapy can be considered in patients with poor PS comorbidities and or high disease volume. Now coming to prophylactic cranial irradiation, that is PCI, more than 50% risk of brain metastasis in SCLC is there. PCI prevents this. It is recommended for a limited stage SCLC with good response, good PS, and age less than 60 in the US or less than 70 in Europe. Use depends on clinical factors, patient preference, and risk of neurotoxicity. It improved 3-year OS by 5.4% and cuts brain metastasis risk by almost 50%. MRI surveillance versus PCI under study for better brain metastasis monitoring. Coming to immunotherapy in SCLC. So for first line extensive stage SCLC, we have 2 approved immunotherapy regimens. The first one is durvalumab with etoposide cisplatin or etoposide carboplatin. It is an NCCN category 1 recommendation. The second one is the atezolizumab plus etoposide and carboplatin, again in NCCN category 1 indication. If these are not possible, then chemo alone is preferred. And in the sensitive patient, you can continue with the immunotherapy maintenance, and on progression, second line treatment is preferred. And if it is primary refractory or no response to first-line therapy or progression within the first 3 months, then second-line therapy, that is topotecan, lurbinectidine or clinical trial is preferred. If no treatment is available or the patient is having poor performance status, then best supportive care or local RT or clinical trial is recommended. So the NCCN guidelines say less than 6 months after the completion of therapy, if the patient is relapsing, then it is considered as a resistant disease, while ESMO says a little more stringent, that is they take a criteria of less than 3 months for calling resistant SCLC. Coming to durvalumab in limited stage SCLC, this was the landmark Adriatic study. It was a phase 3 randomized double-blind placebo-controlled multi-centric international study. Stage 1 to 3 NSC, limited stage SCLC, including the stage 1 and 2, which were inoperable. WHO PS 0 to 1 and who had not progressed following concurrent chemoradiotherapy. PCI was permitted before randomization. So 730 patients were randomized to durvalumab 1500 mg every 4 weekly versus placebo every 4 weekly. The CTRT included 4 cycles of platinum and etoposide, and radiation was given in 60 to 66 gray in daily dosing over 6 weeks, or 45 gray in twice daily dosing over 3 weeks. And RT must have commenced no later than the end of cycle 2 of chemotherapy. So the dual primary endpoints were OS and PFS, and the key secondary endpoints were durvalumab plus tremelimumab versus placebo, which was, the third arm which was taken. So we won't be discussing that here. The disease stratification was by disease stage and PCI. The treatment was continued for a maximum of 24 months. Now coming to the baseline characteristics, median age was around 62 years. Around 2/3 were male. Half of the patients were Asians. The performance status equally distributed between PS 0 and 1. And majority of the patients were current or former smokers. Only around 9 to 10% were never smokers. And majority of the patient had AGCC stage 3 at diagnosis. And around 2/3 of the patient received cisplatin plus etoposide. And again, majority of the patient, around more than 70%, received radiotherapy in the once daily schedule. And the best response to therapy, majority of the patient had a partial response, around 75%, and around 12 to 15% had stable disease. And little more than half of the patient had prior PCI before going to randomization. So now coming to the overall survival, which was one of the dual primary endpoints. So at the median follow-up of 37.2 months, the median overall survival was 55.9 months in the durvalumab arm versus 33.4 months in the placebo arm. So almost 22 months of extended survival, which is a very, very big difference when we talk about small cell lung cancer. The hazard ratio was 0.73, p-value of 0.0104. So if we look at the 3-year survival was again prolonged, 56.5% versus 47.6%. So almost 9% difference here. So durvalumab is the first and the only immunotherapy to show a median overall survival of 55.9 months and a 3-year OS rate of 56.5%. So the overall survival was consistent across all the subgroups. And the second endpoint was the progression-free survival at the median duration of 27.6 months follow-up. Again, the median PFS was prolonged significantly, 16.6 months with the durvalumab arm versus 9.2 in the placebo arm. Hazard ratio 0.76. And if we look at the PFS curve, the 2-year PFS with the durva arm was 46.2 versus 34.2 in the placebo arm. So again, durvalumab is the first and the only immunotherapy to show a median progression-free survival of 16.6 months and a 2-year PFS rate of 46.2 months. Similar to OS, the progression-free survival again was consistent across almost all the subgroups. Now coming to the benefit of prophylactic cranial irradiation in limited stage SCLC, which is still not clear. We have some data which are showing benefit while the others are showing not much if we are using MRI for surveillance. So again, if we see here, the meta-analysis has shown some benefit of PCI and SCLC. This was a meta-analysis of 28 studies, which included more than 18,500 patients. But the limitation of this study, this meta-analysis, was there were very small studies which were included, and the follow-up brain MRI was not uniform across all these studies. And there was also some studies which were non-randomized. So this meta-analysis was criticized for these deficiencies. But we have data, there's Japanese data that says that with brain MRI every 2 months, I think PCI might not be needed at all. So the benefit of PCI in SCLC is still not clear. We do not have evidence from our RCT as of now. The future prospective RCT will clear the clouds around benefit of PCI. So these are recruiting the primal lung study and the Maverick study, which are ongoing. Now coming to the subgroup analysis, if we see with respect to overall survival, patient received who received durvalumab benefited from it, irrespective of whether they received prior PCI or not. If we look at the Kaplan-Meier curves, they are separating for both these subgroups. If the patient who received PCI, the median OS was not reached versus 42.5 months, hazard ratio of 0.75. The patient who did not receive PCI, again, median OS 37.3 versus 24.1, hazard ratio of 0.71. So both of these subgroups are actually benefiting, but irrespective of whether they received PCI or not. Similar analysis has been shown in the PFS subgroups. If we see the 2-year PFS, the median PFS in patient who received PCI was 28.2 versus 13, and who did not receive PCI, it was 9.1 versus 7.4. So again, both of these subgroups are benefiting whether they received PCI or not. The progression-free survival was better for those who received durvalumab than placebo group, irrespective of PCI being received or not. Then the most frequent adverse events, the adverse event profile was consistent with the known adverse events of durvalumab reported in the earlier trial. There were no new adverse events which were reported. The most frequent adverse effect and which are actually of concern are radiation pneumonitis, which was higher in the durvalumab arm. But most of these toxicities were grade 1 or 2, and just over 2%, 1 to 2% had a grade 3 toxicity. Then we also had increased risk of pneumonitis, not just radiation pneumonitis, just pneumonitis also. Then there was slightly higher risk of hypothyroidism, decreased appetite, cough, pruritus, nausea, fatigue, as well as diarrhea. While headache, arthralgias, and constipation, they were more common in the placebo. So to conclude, durvalumab is the first and only approved immunotherapy in limited stage SCLC to demonstrate statistically significant improvement in OS and PFS. Treatment for LS-SCLC is given with curative intent. Despite initial high response rates to chemoradiotherapy, long-term outcomes remain poor. Concurrent chemoradiotherapy is currently the standard of care treatment for LS-SCLC. Durvalumab as consolidation therapy after CCRT demonstrated statistically significantly and clinically meaningful improvement in overall survival and PFS compared with placebo. The OS was significantly prolonged, median OS 55.9 months versus 33.4 months with a hazard ratio of 0.73. The PFS was again prolonged, median PFS 16.6 versus 9.2 and a hazard ratio 0.76. Durvalumab consolidation treatment was well tolerated for up to 2 years, and safety findings were consistent with the known safety profile of durvalumab monotherapy post-CCRT. So durvalumab is the only immunotherapy approved across stages of SCLC, both limited stage and extensive stage. Thank you, and if there are any questions, I would like to welcome.
Thank you,
If not,
sir.
I think we can proceed further.
Yeah. So for the next talk, I would like to invite Dr. Deepak Singla. He's consultant medical oncology from Indus Hospital, Dera Basi, Mohalli. So the stage is all yours.
Yes. Good evening, everyone, and
Good evening,
uh,
sir.
good evening. And thank you, Priyanshu, for giving me this opportunity. And thanks the organizer for conducting this webinar. And thanks Roche for providing these slides. Topic given to me is the redefining management of non-small cell lung cancer with atezolizumab now, and what is next. Next slide, please. Mm. Next slide, next. Yes. So as we know that treatment option for first patient with metastatic non-small cell lung cancer who do not have any actionable driver mutation, first line option is chemotherapy or anti-angiogenic or VEGF inhibitor plus chemotherapy, and second line options are, again the second line chemotherapy or anti-angiogenic chemotherapy, and a drug, which the drug which is already been used, it cannot be used in the second line once again. Next slide, please. So, uh, the treatment of non-small cell carcinoma is evolving, as we all of us knowing that in 2018 and 19, that IM Power 150 came, which gave the approval of four drugs combination, ABCP, in which nab-paclitaxel plus carboplatin and atezolizumab and plus VEGF inhibitor bevacizumab, and followed by IM Power 130, in which the VEGF bevacizumab was removed, and the triplet therapy, and the first line also metastatic non-small lung carcinoma, IM Power 110 in 2021, in which a single agent of atezolizumab was used. So we will be discussing predominantly this three trials, as well as IM Power 010, which was in the role of IO in the adjuvant setting. Next slide, please. So atezolizumab in the first line of metastatic non-small cell lung cancer. Uh, uh, Next slide, please. We know that IM Power 110, in which in the ARMA, atezolizumab was compared with the conventional chemotherapy. In the IM Power, in which the IM Power 130, in which atezolizumab was added, in which the atezolizumab was added in addition to the chemotherapy, and IM Power 150, we know that for drug combination. So next slide, please. So starting with the IM Power 110, in the atezolizumab used in the monotherapy versus the chemotherapy in the PDL1 selected, first line non-small cell lung cancer, it was randomized into 1:1 ratio, and the eligible criteria was stage 4 non-squamous or squamous non-small cell lung cancer, chemotherapy naive, PDL1 selected, EGFR no target mutation, stratification, sex, ECOG, performance data, histology, PDL1, ISC expression. Total number of one patient was 572, and in one arm, atezolizumab was given Q3 weekly, as well as in the versus carboplatin plus pemetrexed, or while in the squamous, it was carbo versus carbo or cisplatin plus gemcitabine, followed by maintenance atezolizumab, and in the non-squamous arm, it was pemetrexed. Next slide, please. And the primary endpoint was overall survival in the wild type, excluding the patient EGFR positive and L positive non-small cell lung cancer. So we can see that primary endpoint of overall survival was seen in the
Shall, can you call, sir? I think there is some issue.
Yeah, I'm checking.
Okay.
Hello,
Hello, am I
Deepak.
audible now?
Yeah, you're audible,
Uh,
sir.
You can switch off your video and save some bandwidth if you're traveling.
Benefit also, OS benefit also, with a single agent analysis of the tumor cell 3 and immune cell 3 in the wild type population. In the tumor cell 3 and the immune cell 3 in the non-targetable mutation, and the response rate was overall median duration of response was 38.9 months versus 8.3. Next slide, please. Next slide, Vishal. Next slide. Next slide. Can you move the slide, please, Vishal? बाहर ले मैं तो. Yeah. Next slide. Next slide. Hello.
Yes, sir.
Am I audible? Yeah, next. So all the and the advertisement was slightly there was a more than 5% difference between the arms updated. So major chemotherapy arm was having majority of the hematological toxicity, while the immunotherapy arm was having a next slide. While the immunotherapy arm was having a immune related toxicity, like in the form of arthralgia, pruritus, hypothyroidism, increase liver enzyme, as well as the rash. Next slide, Vishal. Next slide. So, in summary of next slide. In summary of IM Power 110, summary, the IM Power is a positive study that demonstrated a statistically significant and clinically meaningful overall survival in the tumor cell 3 and the immune cell 3 wild type population versus platinum based chemotherapy with a hazard ratio of 0.59 with a p value of 0.0106 in the TC3 tumor cell 3 and the immune cell 3 wild type population. Atezolizumab showed a meaningful improvement in the progression-free survival, overall response rate, and duration of the response versus chemotherapy. The safety profile of atezolizumab was consistent with the prior observation. No new unexpected safety signal were identified. Next slide, please. So, coming to the IM Power 130, non-squamous non-small cell lung cancer, which was a phase 3 study of carboplatin versus nab-paclitaxel with or without atezolizumab, first line advance in the non-squamous cell, non-small cell carcinoma. Next slide, please. So basically, it is a steroid sparing regimen. Trial design and the eligibility criteria: same chemotherapy naive and the ECOG 0 to 1, statistic factors: sex, PDL1, IS expression, liver mets, and intention to treat population were number 723, and wild type was 679. In the arm, in addition to chemotherapy, atezolizumab was added. 4 to 6 cycle of chemotherapy was given and followed by maintenance atezolizumab till the progression of the disease. As second was only carboplatin plus paclitaxel, followed by pemetrexed maintenance or best supportive care until the end of the progression of the disease. Next slide, please. So cancer immunotherapy, when it is combined with the chemotherapy, could offer a improved outcome in the non-small cell lung cancer, because when the chemotherapy, we are giving the chemotherapy, it leads to the immunogenic cell death and may trigger the release of the cancer tumor antigen, which was presented, which was cancer antigen, then followed by cancer antigen presentation, and followed by PDL expression prevent the T cell priming and the activation in the lymph nodes priming. And next stage is trafficking of the T cells. When we are giving the PDL1 inhibitor, so the T cell priming and the activation in the lymph node doesn't occur, and directly the T cells were trafficking to the tumor, and infiltration of the T cell in the tumor, recognition of the cancer cells by the T cell, and leading to the killing of the cancer cell. Next, so rationale of combining Tecentriq with a nab-paclitaxel versus paclitaxel. So basically it is a nab-paclitaxel is steroid sparing regimen. So next slide, please. Because the steroids are quite immunosuppressive and reduce the efficacy of cancer immunotherapies. Next slide, please. Vishal, next, please. So I investigation as IM power 130 investigation PFS was significantly improved with the addition of atezolizumab in addition to the carboplatin plus nab-paclitaxel in the wild type population, and the PFS at the 6 months it was 56.1%, while in the chemotherapy arm was it a 42.5%. So clear cut 14% of advantage. At the 12-month it was doubled, 29 versus 14. So median all follow-up was with the AT arm plus chemotherapy, it was 18.5 months, while the chemotherapy arm was 19.2 months, and with a hazard ratio 0.64. So median PFS was observed in immunotherapy plus chemotherapy arm was 7 months versus 5.5 months in the chemotherapy arm only. Next slide, please. So there is subgroup analysis in IM power 130. The PFS was significantly PFS benefit was observed across the clinically relevant subgroup in the intention to treat wild type population. So patients with the patients with the PDL1 high, the median PFS was observed the 6.4. The PDL1 low, so even in the PDL1 negative also, there was a median PFS was 6.2. So we can so the conclusion from this slide that even in the PDL1 negative patient where the tumor cell is zero or immune cell is zero, I mean those patients are also derive the benefit from the atezolizumab immunotherapy. Next slide, please. So IM power overall survival significantly improved with the addition of the atezolizumab to carboplatin and nab-paclitaxel. So overall survival was 63.1% at 1 year, and the second year it was 39.6%, while the chemotherapy arm it was 55.5, but at the end of the 2 years it was 30% only. So median follow-up was, as we discussed, and the hazard ratio is a 0.79. 0.79. So not only that, IM power 130 overall response rate and duration of response were improved with the addition of atezolizumab. Next slide, please. Vishal, can you move the slide, please? Next slide, please. Next. So IM power 130 overall response rate and duration of response were improved with the addition of atezolizumab to chemotherapy in intention to treat wild type patients. So overall response rate was 49.2%, and the complete response was observed in the 2.5% of the patient, while partial response was 46.8. Stable disease observed in the 30.4%, while the progression of disease 11%, versus 18.1. The median duration of response was 8.4 months versus 6.1. And the ongoing response is still going on, uh, 36.8% of the patient, while comparatively to 19.4% of the chemotherapy arm. Next slide, please. So IM power summary that IM power 130 met its co-primary PFS and overall survival endpoint and demonstrated a statistically significant and clinically meaningful benefit at 4.7 months overall survival and 1.5 months of PFS for 80 plus chemotherapy in intention to treat wild type population compared with the chemotherapy alone. Overall survival and PFS benefit was observed uh, across the all PDL1 subgroups. 80 plus chemotherapy safety profile consistent with the adverse event associated with a single agent only. No new safety signals were identified. The IM power 130 result thus support the 80 plus chemotherapy as a treatment option for the patient with the advanced non-squamous cell lung carcinoma. So coming to the IM power 150, next slide please. Phase 3 study in which all the four drugs were added 80 plus chemotherapy. And next slide. 80 plus chemo plus bevacizumab in the first line advanced non-squamous cell carcinoma. So basically, it was a random 3-arm based study. Arm A in which the 80 plus chemotherapy, in Arm B in which the 4 drugs were used, and in the Arm C it was only the chemotherapy plus the bevacizumab. So the endpoint was PFS in intention to treat and uh, overall survival in intention to treat wild type patients. Next slide, please. So baseline characteristics were well balanced in the between arms. So and the most important point is the 14% of the patient had liver metastasis at baseline, which were also a stratification factor in IM power 150. 10% of the patient had a EGFR mutation, and these patients were balanced across the all the 3 arms. There was approximately 50 to 50 split between the PDL1 positive and the negative patients. Next slide, please. So there was significantly over a survival benefit was seen in the addition of atezolizumab in the intention to treat wild type patient arm B versus arm C. So overall survival uh, at the end of 12 months it was 67%, while in the IO negative arm, like in the arm C, it was 61%, and in the 18 months at 53% versus 41%, and 24 months it 43 versus 34%. The improvement in the median OS is 4.5 months in the which is clinically meaningful, and a median overall survival was 19.5 months versus 14.7 months. Next slide, please. So overall response rate. Next slide, please. Next slide, Vishal. Overall response rate and duration of response were improved uh, uh, in the intention to treat population. Next, so overall survival benefit are observed in the all PDL1 subgroup in the intention to treat wild type patient arm B versus arm V, PDL high, ABCP versus BCP. So PDL high patient derived the most benefit, and the overall survival median overall survival was 30 months versus the 15 months. But however, the PDL high patient drive the most significant benefit. Next slide, please. So overall survival was observed across all the this is the same PDL positive, whether it is TC123 versus immune cell 123, and the overall survival was 22.5 months versus the 16.0 months. And the PDL negative also median overall survival was 16.9 months versus 14.1 months. Next slide, please. And the efficacy in the key subgroup, it was EGFR positive patient after the progression on the TKI. So EGFR positive subgroup patient in IM power 150. Total number of patients were 1,202. In intention to treat patient wild type 1042, and while the EGFR mutant and or ALK arrangement only it was the 160, EGFR 124, and sensitizing mutation 91. Next slide, please. So clinically meaningful PFS was benefited and observed in the arm B versus arm C in patient with the EGFR EGFR mutated patient plus ALK positive patient, and in the non-small cell carcinoma, the PFS Kaplan. I mean, we can see that PFS Kaplan-Meier curves are starting separated after 6 months, and the median PFS was observed 9.7 months in the in the EGFR positive plus ALK positive patients versus median versus 6.1 months in the non-immunotherapy arm. Next slide, please. So overall survival was benefit in the patient with the EGFR mutation, arm A versus the arm C. There was a continued clear separation of curves in and overall survival benefit. The addition of atezolizumab to bevacizumab plus chemotherapy. If we compare arm A, arm C, arm A versus arm C, and median overall survival was 19 months versus 18.1 months, while in the arm B and arm C it was 29.4 months versus 18.1 months. And so that four drug combination, it do work very well in the like in the EGFR mutated patient who are already exposed to the TKI therapy. Next slide, please. So there was a continued clear-cut separation of the curve and the overall survival benefit with the addition chemotherapy in arm B, which was a 4 combination therapy, arm C, which was 3 combination of therapy, excluding the immunotherapy. The median OS was 27.8 months versus median OS of 18.1 months in the chemo plus bevacizumab arm. And while in the case of
Sir, sorry to interrupt you. Please conclude your talk in next 2 minutes.
okay, so let's coming to the subgroup in the liver metastasis. Patients with the liver metastasis also derived the maximum benefit benefit with all the 4 combination of chemotherapy with the median PFS of 8.2 versus 5.4 months, and the overall survival benefit was also observed in the in this group. The like overall survival was 13.2 months versus 9.1 months, and while the no overall survivals benefit was seen in the arm A and the arm C. Next slide, please. So addition of bevacizumab to atezolizumab chemotherapy, overall response rate and the duration of response patient in the liver mets. Next slide, please. Next slide. So patient with the maximum bulky disease also derive the maximum benefit with the addition of the atezolizumab, all the 4 combination of the therapy. Next slide, please. So so to conclude, IM power 150, the IM power, or which was the 4 combination study. Next slide, please. So patient with the PDL negative, high burden disease with the liver metastasis, patient who have already been exposed to the TKI with the EGFR mutation and ALK positive, they also drive the PFS and overall survival, duration of response, and durability of the response was much better with the addition of the immunotherapy arm. So in summary, IM power 110 atazolizumab monotherapy with a high PDL1 expression, both squamous and non-squamous histology. IM power 130. Atazolizumab plus chemotherapy is a steroid sparing regimen. PDL1 all corner, even the PDL expression less than 1%. Like option is in patient with a comorbidity and the uncontrolled diabetes and renal dysfunction. IM power, which is a four drug combination, PDL all corners, significant benefits in the patient in the liver mets, bulky disease, progress on the TKIs. So in the adjuvant setting, I will not discuss because of the time. So is there is any question I would like to answer on based upon these all three trials?
Thank you, sir.
Thank you so much, Priyanshu, for giving this
Thank you, sir.
opportunity.
Thank you, sir, for your valuable time.
Thank you so much.
Angi, can we proceed further?
Yeah. So for the next talk, I would like to invite Dr. Manish Sharma. He's consultant and head of unit medical oncology, Positron Super Speciality and Cancer Hospital, Rohtak.
Good evening, Dr. Priyanshu.
Good evening, sir. Welcome again, and thank you for your valuable time.
Thank you. My slides are visible, no?
Not
My
yet.
screen.
Screen
my
is
screen
visible,
is-
but slides are not.
Just a second. So thank you so much, Dr. Priyanshu, for inviting me. And I will
Thank
be
you, sir.
speaking on ALK rearranged advanced NSCLCs. So with the focus on lorlatinib. So this is the overview. We'll be speaking on the drug design mechanism, then speaking about the CROWN trial, subgroup analysis, resistant pattern, and then safety. So, as per Globocon 2020, approximately 72,000 new cases of lung cancer they were detected in India, and by 2040 the number would double to around 120,000. And the lung cancer with distant metastasis occurs in male to the tune of 44%, and in females it is 47%. And as per same Globocon 2020, the number of deaths in due to lung cancer in India were 66,000, which will increase to 110,000 by year 2040. And on the right hand side, you can see the most common cancers: breast, cervix, oral cavity, and the lung is the fourth most common cancer overall. So these lung cancers, non-small cell lung cancer, particularly adenocarcinomas, they are oncogene-erected tumors, and they respond beautifully to oral targeted therapies. And these are various kind of mutations and rearrangement which we find in in the NSCLC, which include MEK, MET, NRAS, PIK3, BRAF, B2, etc. So ALK, the incidence varies from 1.6 to 11.7%. And typically, we find the ALK incidence to be around 5%. Typical patient is adenocarcinoma histology, non-smoker or light smoker. They tend to be younger patients. And EML4 ALK and EGFR mutations, they are mutually exclusive. If one has EGFR mutation, ALK will not be there. So ALK has multiple number of partners, which include TGF, KIF. EML4 is the most common partner for the ALK rearrangement. So basically what is happening, a small number of NSCLC patients, they have inversion of chromosome 2, which causes the fusion of ALK gene with EML4 gene, resulting in EML4 ALK fusion protein, leading to the downstream activation of the growth pathways, and this was initially reported in 2007. So there is unmet need. These patients, they tend to be younger, non-smoker, light smoker, and these patients, they tend to have CNS metastasis to the tune of 20 to 40%. So lung cancer as such uh, is a grave cancer to have. Apart from that, those patients who have CNS metastasis, they have even poorer prognosis. And the ALK rearranged patients, they have this to the tune of 20 to 40%. So there are second generation and first generation ALK TKIs available with us, which are crizotinib, alectinib, but the penetration in the CNS is limited in these ALK TKI, and the duration control of the brain metastasis, uh, preventing the brain metastasis, is also limited with these first and second generation ALK TKI. So, in the newly diagnosed ALK positive patient, ALK positive NSCLC, the incidence of brain metastasis can range from 20 to 30%, and international guidelines recommend testing CNS metastasis at diagnosis through cranial MRI. So, uniformly in all of our patients with lung cancer, whether it is small cell, non-small cell, we are doing a MRI irrespective of the PET-CT finding. And the several ALK-TKI have been evaluated in the first line, and those patients who have baseline brain metastasis, demonstrating the prolonging PFS and the intracranial efficacy. So lorlatinib has been specifically designed to penetrate the blood-brain barrier and provide the good penetration and disease control in the brain. And this is the FDA approved drug nowadays for ALK rearranged NSCLC. So you can see that 3-year cumulative brain metastasis is to the tune of 58.4%, and at baseline, approximately 23% patient, they have brain metastasis. So 23% at the baseline, and those patients who survive for 3 years, the cumulative incidence goes up to around 58% for ALK rearranged TKI. So we have to choose from what we have available, and we look for overall efficacy, overall survival, what are the second line options, CNS activity. I think this is the most important thing, very, very important thing, response rates, and the progression-free survival. So as I discussed, this is a third generation ALK-TKI, which has been specifically designed to penetrate brain and to address the brain metastasis. It improves the clinical outcome with overall and intracranial efficacy activity in the patient with previously untreated ALK positive NSCLC. And upfront treatment can completely suppress or at least significantly delay the on-target resistant mutation which happen with the first or second generation ALK-TKI. This is the structure of crizotinib and lorlatinib. Effective penetration in CNS is limited with crizotinib, but or lorlatinib, it has high CNS penetration, as well as the binding with the ALK resistant mutation is significant with the lorlatinib as compared to the crizotinib, which is the first generation ALK TKI. So coming on to the lorlatinib phase 3 CROWN trial, these patients, they were stage 4B to 4, ALK positive patient who did not receive any treatment. Asymptomatic CNS metastasis was permitted, and more than equal to one extracranial measurable lesion should have been there, with no prior radiation required for these patients. And these patients were randomized in 1:1 fashion to lorlatinib 100 milligram once a day or crizotinib, which is the standard of care. And the primary endpoints were progression-free survival. Secondary endpoint, there are a number of secondary endpoints which include overall survival, safety, quality of life, intracranial efficacy, progression-free survival, and overall response rate. So these are the baseline clinical characteristics. Patients' baseline median age was 60 years, male and female equally divided. Significant representation from the Asian population, 54% non-smokers, 37% previous smokers, and 9% current smoker. 94% patient, they had adenocarcinoma, 2% patient they had squamous, and 4% patient they had adenosquamous histology. With baseline brain metastasis present in quarter of the patient, so approximately 1/4 of the patient they had brain metastasis, of which 6% patient they had prior brain radiotherapy. Otherwise, 20% patients did not have any radiotherapy for the brain metastasis. So this was the primary endpoint of the progression-free survival by independent committee review, and it was met. You can see significant PFS advantage in the lorlatinib arm as compared to the crizotinib arm. So 12-month PFS rate was 78% versus 39% for the crizotinib, and the hazard ratios were statistically significant. Coming on to the 5-year analysis efficacy of the Crown trial. So this was the PFS over the period of 5 years, and the 60% 5-year PFS rate you can see with the lorlatinib as compared to the 8% with the crizotinib. Median PFS not reached versus for crizotinib it was 9.1 months, and the hazard ratios 0.19, which is statistically significant. And this is the efficacy in the patients who had baseline brain metastasis. With baseline brain metastasis, the hazard ratios are 0.08, and the PFS not reached versus 6 months with crizotinib. So in both patients with or without baseline brain metastasis, lorlatinib improved PFS with median PFS not reached in the either group. So you can see the side-by-side comparison of the Crown and Alex trial for the PFS. This is the cross-trial comparison, but yes, we can find that the hazard ratios for the Crown trial was 0.19, while for Alex trial it was 0.34. Median PFS not reached for Crown trial versus 34.8 months for the Alex trial with the alectinib. Especially, you can see there is a significant intracranial efficacy. After 36 months, you can see none of the patient has progressed in brain. So it delays the intracranial progression. The patients without intracranial progression were 92% at 5 year, and hazard ratio, you can see it was 0.06, which was statistically significant. And similarly, the time to intracranial progression, those patients who had brain metastasis or those patients who did not had the brain metastasis, the hazard ratios were statistically significant. Those patients who had brain metastasis, the median PFS not reached. Similarly, those without brain metastasis, median PFS not reached. So intracranial time to progression also significantly more in case of lorlatinib in the Crown trial compared to the alectinib in the Alex trial. Intracranial time to progression at 60 months for lorlatinib significant as compared to the crizotinib, while it is not available for alectinib versus crizotinib in the Alex trial. So in patients with baseline brain metastasis, lorlatinib resulted in high intracranial responses, and majority of which were complete and durable response. So you can see that the complete intracranial response in the lorlatinib arm was 58%, very high as compared to the Alex, which was 38%. So coming on to the subgroup analysis. Subgroup analysis for these patients. So V3 variant of the ALK is a subgroup which has a very poor prognosis, and even in these V3 variants, ALK fusion variants, you can see that lorlatinib had 60 months of progression-free survival, median progression-free survival, which was just 17.7 months with the alectinib in the Alex trial. Similarly, we consider P53 mutations to be bad for these patients. These are difficult to treat population, but here you can see the median PFS in P53 mutated patient was 51.6 months. So, coming on to network meta-analysis, we have nowadays plenty of ALK TKI available with us. So which one to choose from? And this is a network meta-analysis which looks towards the hazard ratios of progression compared to the other treatment as compared to the lorlatinib. So the trials included here were Crown, Alta, LX, JLX, and the Ascent trial with the ceritinib and the Profile trial. So you can see that on the right hand side, the hazard ratios favor lorlatinib against all of the available TKI. And this is an effective first-line treatment for ALK-positive NSCLC when compared to the crizotinib or other next-generation TKI. Immature overall survival data for most of the included studies in the network meta-analysis, and there is still no statistical significant difference between lorlatinib and other treatment for OS. However, OS for the many other studies, it is immature when included in this network meta-analysis. So this is another network meta-analysis of lorlatinib, alectinib, and brigatinib in the treatment-naive patient of ALK positive, ALK rearranged NSCLC. And in terms of PFS, the results indicate that the lorlatinib was the best treatment choice for the patients with ALK inhibitor naive untreated patients, ALK positive patients. And future head-to-head trial assessing the relative efficacy of the lorlatinib, alectinib, and brigatinib, they are needed. So this is the network plot of the different comparison with brigatinib, alectinib, and lorlatinib, and the hazard ratios, they favor lorlatinib over alectinib or brigatinib, with lorlatinib having significant PFS advantage as compared to the brigatinib and alectinib. This is the subgroup analysis of the ALK positive TKI for ALK inhibitor naive ALK positive NSCLC versus alectinib and brigatinib in this network meta-analysis. Approximately for all the subsets, irrespective of age, sex, race, or smoking status, or CNS metastasis, the network meta-analysis favors the use of lorlatinib over ALK TKI. So this is the conclusion of the network meta-analysis. In terms of PFS, results indicate that lorlatinib was the best treatment as compared to the other ALK inhibitors, and it has probability to reach the best overall confirmed response rate to the tune of 48%, and the intracranial confirmed responses to the tune of 44%, and has significant improved PFS than brigatinib and alectinib, hazard ratios being 0.57 and 0.58. So coming on to the resistant pattern after ALK TKI, so what happens if we use first generation or second generation ALK TKI upfront and then keep the lorlatinib for the second line treatment? So there is the evidence that once these patients are exposed to first generation or second generation ALK TKI, there is the emergence of on target resistance which happens in these patients. And these are various mutations which can arise. And lorlatinib has been designed to take care of all these kind of mutations which arise in the alectinib or ceritinib or crizotinib treated patient. And once the lorlatinib is used in the first line treatment, these mutations, they do not arise in the first place. So this is how the more generations of ALK TKI, if sequenced in the first, second, or third line treatment, then more number of the monster ALK resistant mutations they appear, and hence there is a rationale for the upfront use of pan inhibitory agent. If the upfront we use the lorlatinib, which is a pan inhibitory agent which takes care of all these kind of mutations which arise in ALK. If you use first generation or second generation, then there is a significant delay or suppression of on-target resistant mutations. So this is one of the lorlatinib phase 2 trial, and you can see that the resistance mechanism for first-line lorlatinib. So over the period of 5 years, new single ALK mutation which arose in lorlatinib was 0, and no ALK compound mutation happened in these 31 patients who received the lorlatinib. So there is no emerging new ALK resistant mutation that were detected in the circulating tumor DNA collected at the end of the lorlatinib treatment.
Sir,
So
sorry to interrupt you. Please conclude your talk in next 2 minutes.
Yes. So coming on to the safety profile, um, so so these are the adverse events which happen with the use of lorlatinib, and the most important being lipid profile derangement, edema, peripheral neuropathy, weight gain, fatigue, arthralgia, and the cognitive dysfunction. So the hypertriglyceridemia occurs in almost 1/4 of the patient. 20%, 22% patient, they will have significant weight gain, and hypertension in 12% patient. So these are the adverse events: cognitive, mood, speech, and psychotic effect. So uh, so the lorlatinib safety profile was consistent with the primary analysis, and these are the treatment-related adverse events which we have already discussed. But the important thing was that the dose reduction did not compromise the systemic or intracranial efficacy. So the dose modification in the Crown trial, 23% patients were dose reduced, 62% had temporary discontinuation, and 11% patient they had permanent discontinuation. But as we discussed in the previous slide, dose reduction or the temporary discontinuation did not lead to the decreased overall survival or PFS advantage for these patients. So this is with the dose reduction within 16 weeks, the PFS not reached with or without dose reduction. So it does not appear to impact the progression-free survival. So after 5 years, the PFS has yet to be reached. Lorlatinib delays the intracranial progression, and it protects against development of the new brain metastasis. With longer exposure to lorlatinib, frequency and the severity of the side effects, they were in line with the previous analysis, and the frequency of the permanent discontinuation was numerically similar in the lorlatinib and crizotinib arm. Thank you so much for your patient listening.
Thank you, sir.
Thank you, sir.
In the interest of
So,
time, we'll be moving forward.
yeah. So for our next talk, I would like to invite Dr. Navdeep Singh, his consultant medical oncology from Deep Hospital, Ludhiana.
I think you need to update. I am right now working at AUI Jalandhar. Hello, Dr. Priyanshu.
Hi, Dr. Nadeep. Your CV is not updated by these guys.
They always write me in Ludhiana, but I'm working in Jalandhar since last 1.5 years. Okay. So my slides are visible to you?
Yeah. Just make it full screen. Yeah.
A very good evening to all. So today I'll be discussing about PATINA, this phase 3 trial. This trial actually evaluated the efficacy and safety of CDK4/6 inhibitor palbociclib plus endocrine therapy versus anti-HER2 therapy plus endocrine therapy after induction treatment for hormone receptor positive, HER2 positive metastatic breast cancer. So, background of this trial was that approximately we know 15 to 20, or I would say 10%, they breast cancer overexpress HER2, and they can also express the estrogen receptors. The anti-HER2 therapy, we know dual anti-HER2 therapies improve the survival outcome, but yes, around 10 to 15% patient eventually develop resistance to these HER2 therapies. So, what is the rationale for blocking this CDK4/6 in HER2 positive disease? So again, this cyclin CDK4 axis is essential for the initiation and maintenance of growth of HER2-driven mammary carcinomas. So and persistence of this CDK4 cyclin CDK4 activity that drives resistance to the HER2 pathway blockade. So again, if we combine this CDK4 with the HER2, that show this synergistic anti-tumor activity in preclinical models. So and palbociclib, we already know it's a approved drug for MBC, metastatic breast cancer, which is HER2 positive. So discussing on the blockage. So if you see, we know this mechanism of extraction of CDK4/6 inhibitor. The cyclin D1 CDK4 complex inhibits phosphorylation of phosphorylation and ultimately arresting it from G1 to S phase. And even the HER2 pathway, these this PIK3 AKT pathway, mTOR pathway. So they both these pathways converge at a similar tumor suppressor protein gene TSCC2. So when we combine these both drugs, there is a potent inhibition of this RB phosphorylation and mTOR activity, and which enhances the anti-proliferative factors in the tumor cell. So coming to the study design, so this trial was conducted with the patient with the hormone positive, HER2 positive metastatic breast cancer. The induction treatment, the name was given induction treatment when the patient received 6 to 8 cycle of anti-HER2 therapy with the chemotherapy. The common chemotherapy regime used was combination with taxane and vinorelbine. And after the completion of induction therapy, those patients which only achieved CR, PR, or had a stable disease, then they were randomized to these two groups. Group was palbociclib combined with palbociclib combined with anti-HER2 drugs plus endocrine therapy, and the other group in which the CDK4/6 inhibitor was not used, the trastuzumab plus pertuzumab were combined with endocrine therapy. So the stratification factor again the pertuzumab use prior and use of any anti-HER2 therapy and a response to the induction therapy. So these were the statistical point. The PFS was the investigated assessed PFS was the primary endpoint. The other endpoints like objectives, overall survival, objective response rates were there. So around the study was started from 2017 June until July 2021. So 630 patients were screened and 518 were randomized to these two groups. One group had a combination of CDK4 inhibitor with anti-HER2 therapy, the other without this anti-CDK4/6 inhibitor. So median age was around 53 years, and mostly this trial was conducted in Europe. Majority patient again female, median. Then the most of the patient they were prior use of pertuzumab. Around 96.9% patients had a use of pertuzumab in the both arm. And the endocrine therapy commonly used was aromatase inhibitor, and in some patient fulvestrant was also used. And prior history of the anti-HER2 therapy was also present in the neoadjuvant setting. So best response to therapy was assessed as a partial response, complete response, or a stable disease. So look at the primary endpoint, the PFS. See the curves. They started separating from the start. And the PFS median was 44.3 months in this combination with CDK4/6 inhibitor compared to 29.1 with a hazard ratio of 0.74. So look at also this 60 months. There was almost I think say 10% difference in between the two arms, which is quite a significant difference at that point of time. And if you see even the control arm, the PFS is around 29.1 months. And if you see the Cleopatra also, in which also there was a hormone positive, HER2 positive, the PFS was around 18 months. So see, I think this is the good thing. The PFS definitely in this trial is more compared to Cleopatra. And if you see the PFS was as per the subgroup analysis, it almost favored the combination arm. If even patient has received the prior anti-HER2 therapy or it has not received anti-HER2 therapy, and even with the if there is a best response to the induction therapy, patient achieved CR or a PR, and even if it is stable disease, all the factors these favored this combination group. And if you see the secondary endpoint, the objective response rate and clinical benefit rate, again, in this combination, it was 29.9% versus 22.2% with a p-value of 0.46, the overall response rate. And the clinical benefit response, again, both had a difference with 89.3% in the combination of palbociclib versus 81.3 in the only anti-HER2 and anti-endocrine therapy with a p-value of 0.01. So secondary endpoint, overall survival again, in the combination arm, still the median OS is not evaluated, but yes, it is 77 months in the anti-HER2 and endocrine therapy arm. So we are always worried about the side effects. If you see the common, we know with the CDK4/6 inhibitor, the neutropenia and all the things are common. So these are the common side effects which happened in the both arms: neutropenia, fatigue, stomatitis. Again, in the combination with the palbociclib, these side effects were more. Diarrhea was also a common reported side effect in the combination arm. However, the incidence of grade 4 adverse events were similar in both the arms. Treatment discontinuation was reported in 7.5% patient in the pelbosic arm. There were no treatment-related deaths in either arm of the study. So to conclude, this result reinforced the strong scientific rationale for overcoming the resistance of anti-HER2 therapy and endocrine therapy by adding CDK4/6 inhibition. So the addition of palbociclib to anti-HER2 and endocrine therapy demonstrated a statistically significant PFS in the patient of hormone positive, HER2 positive in the first line metastatic setting. Palbociclib added to anti-HER2 and endocrine therapy had a manageable toxicity profile. A few points I want to make. One is again they took only those patients which had a CR stable disease or PR. But what about the patient in which there was a primary resistance? Okay, so whether should we continue the CDK4/6 inhibitor or we should go to TDM1 or TDXD? And second, in most of the patients they used in the induction in the pertuzumab. However, in my practice, in the most of the patient I use a single anti-HER2 mostly trastuzumab. How to interpret these results in these patients, it will be a topic of discussion. Thank you.
Thank you, Dr. Nadeep. I think you have answered a few questions which we were going to ask.
Okay.
Thank you so much.
Thank
And now
you.
we'll move on to the next session.
So for the next session, I would like to invite Dr. Kanupriya Bhatia. She is medical oncology from Ludhiana.
Thank you. I'll just share my screen first. So are my slides visible?
Yeah, ma'am.
Okay. Hi, Priyanshu sir, and thank you for
Hi,
giving
Dr.
me the
Kanupriya.
opportunity.
How are you?
Hi, good sir. And thank you AstraZeneca for giving me a very relevant topic to talk on this upcoming molecule, which has literally changed the landscape of treating HER2 low breast cancers, metastatic breast cancers, and HER2 positive as well. And it is slowly coming into other cancers as well. So what I'm talking today is how HER2 is used for the treatment of HER2 low metastatic breast cancers. So I'll start with what actually HER2 low breast cancer is. We'll touch on the mechanism of action of these antibodies, the Destiny Breast 04 trial, what is the efficacy and what are the associated side effects with this molecule, and the common day-to-day administration guidelines which can guide us in our practice. So breast cancer, we all know, is the most common cancer worldwide as well, and in India, most common in the females. So we are very familiar with this classification of how do we classify the HER2 in breast cancer. So if the tissue is showing a very strong staining of HER2 in more than 10% of cells, it is labeled as IHC3 positive on immunohistochemistry. If there is no staining, it is labeled as IHC0. When the staining of HER2 antibody is weak or it is in less than 10% of the cell, it is IHC1 positive. If there is a strong staining in less than 10% of the cell or weak in more than 10% of the cell, it is called as IHC2 positive. And it is here in IHC2 positive and in situ hybridization, it actually plays a role. So by FISH, if the sample is positive, we label it as HER2 positive. If by FISH it is negative, we label it as HER2 negative. So for years, we have been following this. There have been only two categories: breast cancers which are HER2 positive and breast cancers which are HER2 negative. So these HER2 negative breast cancers are either hormone positive or hormone negative. Hormone negative are the triple negative one. And talking about how do we treat them in the metastatic setting, beginning with the hormone positive category. Hormone positive category, we obviously begin with endocrine therapy if the patient is not in visceral crisis. Along with CDK4/6 inhibitors, we are able to get a progression-free survival of somewhere 1.5 to 2 years. Then moving on to the second line, we either find a target which has caused the endocrine resistant and we target it using maybe PTEN inhibitor or PI3K inhibitors, or we move on to chemotherapy, and in the third line again chemotherapy. So this is how the protocol of hormone positive metastatic breast cancer goes. If we see the triple negative ones, it's only chemotherapy. It's only recently that antibody drug conjugates are coming into the setting, but the overall survival that we are able to provide to our patients who are triple negative metastatic is very dismal. So this is how the landscape of HER2 has changed now. So broadly speaking, approximately 50% of breast cancers are HER2 low. So what is this HER2 low category? The patients which were IHC2 positive but were FISH negative, they belong to HER2 low, and 1 positive are the ones which are HER2 low. So 50% of all metastatic breast cancers, and this is where Destiny Breast 04 actually targeted. This was what their targetable population was in the second line setting. So this is a major population we are talking about, 50% of metastatic breast cancers which are HER2 low. In hormone positive, almost 2/3 of the patients are HER2 low, and in triple negative, 1/3 of the patients are actually HER2 low. So the NCCN guidelines after the Destiny Breast 04 actually state that in the second line setting, and HER2, which is trastuzumab deruxtecan, is the category 1 recommendation in metastatic HER2 negative disease who are HER2 low at a dose of 5.4 milligram per kg, and it's cycled every 3 weeks. Let's briefly
I think there's some issue with Dr. Kanupriya's connection. Shal, can you contact her? Yeah, she's back.
Sorry, I just lost power. Yeah.
No issue.
I'll just share my screen again. Okay, so briefly discussing how trastuzumab deruxtecan in HER2 actually works. So we have an antibody, which is trastuzumab, our old friend. It is attached to a drug which is topoisomerase inhibitor. It is 10 times more potent than irinotecan, and it is attached using a linker which is very tumor specific. So the target is HER2. Any cell which is going to express any level of HER2, actually, trastuzumab deruxtecan is going to attach on that. The payload is a topoisomerase inhibitor. And the drug to antibody ratio that we are talking about is 8:1. It's a tumor selective linker, which again emphasizes the fact that the amount of adverse events associated with it will be less. And it has a bystander effect as well. So this is how the antibody acts. Actually, this is the HER2 expression on the tumor cells. So, and HER2 will go and bind onto HER2. And there will be an endosomal cycle formation. The drug will be encapsulated and endophagocytosed into the cell. The tumor-specific enzyme will cleave the linker and release the drug into the cell, which will enter the nucleus and then kill the cell. Once the cell dies, some of the drug will leak into the environment and kill the neighboring cells as well, which is called as the bystander effect. So coming on to the Destiny Breast 04 trial. So open label phase 3 trial, where in second or third line setting, HER2 low breast cancer were randomized into either receiving Enhertu or chemotherapy of the physician's choice. And the point of interest here is that the primary endpoint was progression-free survival in hormone-positive breast cancers. The secondary endpoints did include PFS in all comers, OS in hormone positive as well as in all comers. So the demographics was well balanced between the two groups, and here that we see that most of the patients actually were hormone positive. Around 90% of the patients were hormone positive. Only 10% of the patients were triple negative in Destiny Breast 04. Around 5% of patients had brain metastasis in this trial, and majority of them, approximately 70%, had liver metastasis also. So the disease burden was very high in these patients. And this is how many prior lines of therapy these patients had received. They were actually very heavily pre-treated patients. So we must know that their PS would not be very great. Their fitness would also be not very great. And the ability to tolerate the drugs also decreases with the amount of prior lines of therapy that they had been receiving. So coming on to what efficacy data we saw. So this is in the hormone positive subgroup. So we see that Enhertu as compared to physician choice of chemotherapy was able to give a median progression free survival of 10 months as compared to 5 months, and an overall survival benefit of also 2 years versus 1.5 year was seen. So we got a benefit of more than 6 months. And in all comers also, the progression free survival was also 10 versus 5 months, and overall survival 23 versus 17 months. And HER2 benefited across all the subgroups that were there. It did not matter whether the IHC was 1 positive or 2 positive and FISH negative. The benefit was seen consistently across all subgroups. So like I said, the disease burden in these group of patients was very high. So in such patients, we do aspire to get a quick and a better response rate also. With chemotherapy, we can see that we were getting a response rate ranging from 10 to 15%. As compared to this is a very beautiful slide which shows that almost 50% of patients with Enhertu had shown either some kind of a response to the drug, which is what we want in these patients. So majority of the patients did get a reduction in tumor size with the drug. Then, like I said, only 10% of patients were triple negative. So an exploratory subgroup analysis was done. A PFS benefit of 8.5 versus almost 3 months, and an overall survival benefit was also seen, which is why this is again a standard of care once the other therapies have been used in triple negative breast cancers also. So coming on to, once we've discussed the efficacy, let's talk about the safety data. So we do tend to forget that ADCs are sometimes can be associated with a lot of nausea and vomiting. TDXD is one of the highly emetogenic drugs, nausea being one of the most common side effects, fatigue closely following that. We do see cytopenias also. So almost 1/4 of the patient did require one or the other dose reduction, which were on HER2, although dose reductions were more with chemotherapy. And around 16% of patients did require discontinuation also, mostly because of ILD or pneumonitis associated with HER2. So the pneumonitis was seen in around grade 1 or 2, around 10% of the patients, and 3 deaths occurred in this trial because of grade 5 ILD as well. Quality of life barely was affected by Enhertu. Coming on to how do we actually dose it? It is given at a dose of 5.4 milligram per kg every 21 days. The first cycle we give over 90 minutes, it is diluted in 5% dextrose. And if the patient tolerates the first cycle well, you can give the subsequent cycles over half an hour as well. The first dose reduction from 5.4 is 4.4, and the second is at 3.2, beyond which, if the patient is not able to tolerate, you'll have to stop the treatment. Most common causes for treatment discontinuation are for pneumonitis or left ventricular dysfunction or extreme fatigue or cytopenias. So discussing the common side effects that we have, the important side effects. Clinical examination with SpO2 monitoring, and then every 8 to 12 weeks to do a CT scan of the chest to catch this fatal side effect as early as possible. If a patient has grade 1 pneumonitis, you have to stop the drug, and if the pneumonitis resolves within a month, you can start the drug again at the same dose. If patient develops a grade 2, that is a symptomatic pneumonitis, we'll have to permanently discontinue the drug and treat it with corticosteroids. Similarly, if the patient develops left ventricular dysfunction, if the ejection fraction is still more than 45% and the decrease is less than 10%, we can continue with the same dose, beyond So coming on to the common side effect that we see, nausea and vomiting, I said it is a highly emetogenic drug. So like we manage all the highly emetogenic drugs, treated with steroids, NK1 receptor antagonist, 5-HT3, and olanzapine. I'm not very well experienced with the drug. I've used in 2 or 3 patients. For me, I have not required using olanzapine in them. 3 antiemetics usually the patients do very well with that. Coming on to ILD, which can be fatal if not caught early. Like I said, monitor every patient before the cycle, see what the oxygen saturation is in room air, ask for any cough or any breathlessness, and do an HRCT every 8 to 12 weeks to catch the side effect as early as possible. So once the patient develops a symptomatic ILD, it will require a permanent discontinuation. You be treated with steroids and antibiotics, and yeah, that's it. So that's what I said, that it's very important for the first year the patient is on Enhertu to monitor, because that is when most commonly ILD actually develops. And pulmonary function test and HRCT every 8 to 12 weeks need to be done. So a brief one, just a case presentation. 49-year-old female whose mother also had ovarian cancer and died with it, presented in 2021 February with locally advanced triple negative breast cancer. She was treated with neoadjuvant chemotherapy followed by surgery. Just after finishing the treatment, she developed a metastatic disease, which was biopsied again, was ER negative, PR negative, HER2 positive, FISH negative. So HER2 low disease. PDL1 CPS score was more than 90%. So as expected, was started on pembrolizumab and chemotherapy. Took chemotherapy for 4 months, then was switched to pembrolizumab maintenance, had a PFS of around 6 months. Disease progressed again. A biopsy was done again. She was triple negative. Since she was germline BRCA positive, was started on olaparib, got a PFS of 4 to 5 months. Disease again progressed and was started on Enhertu, because we had one biopsy which was HER2 positive, HER2 low. And since then, she has been doing well on Enhertu. So my summary again, that Enhertu actually has doubled the median PFS in hormone positive HER2 low breast cancer. It also doubles the PFS in triple negative breast cancers. It increases the overall survival also, and most importantly, in these patients with a high burden of disease, which are very symptomatic, be it because of the abdominal pain or the lung mets causing lung symptoms, the overall response rate increase from 15 to 50% is huge. Thank you.
So this session was sponsored by AstraZeneca and HER2. So thank you so much, ma'am, for this talk.
Yeah, thank you.
Thank you, Dr. Kanu.
Thank you, sir.
So our next talk is sponsored by Roche. So I would like to invite Dr. Rajit Ratnan. He's consultant medical and hemato-oncologist. So the stage is all yours.
Hi everyone. Thank you, Dr. Priyanshu, for this opportunity.
Hello, sir. Welcome again.
Your memes also keep on coming, and I believe your Instagram account is growing by the day now.
At least something is going.
I always look forward to your WhatsApp statuses and Instagram. Okay. So, shall we start?
Yeah.
Yeah. Can you share my slides? I have mailed you. Yeah. Thank you, Vishal. So my topic is how HER2 new therapy has transformed the breast cancer patients, and how the subcutaneous form has actually made a lot of strides in this case. Next slide, please. Next. So Perjeta or pertuzumab and Herceptin have transformed the treatment landscape, and they are the standard of care in patients with HER2 positive breast cancer. There have been really 3 pivotal studies in all 3 aspects of breast cancer. First, in the neoadjuvant space, where patients are of high risk, we have the Neosphere study, in which the addition of pertuzumab to the usual Herceptin and chemotherapy has significantly improved the pathological complete response rates from 31% to 49%, compared to when pertuzumab is not used. In the adjuvant space, in high-risk breast cancer patients, especially in node-positive patients, affinity trials showed that the use of or the addition of pertuzumab to the usual drug regime of Herceptin and chemotherapy has shown decrease in the risk of recurrence as well. In the metastatic space, we have the Cleopatra trial showing not only an increase in the median PFS, but also a median OS increase with the use of pertuzumab to the combination of chemotherapy and Herceptin. The median OS increased from 40.8 months to 56.5 months, which was not only significant clinically, but meaningful as well. So now, Perjeta and Herceptin plus chemotherapy, they're approved and recognized by international guidelines as a standard of care in patients with HER2 positive breast cancer. Can we have the next slides? The next slide, please. Yeah. So what do the guidelines say? Guidelines say that whenever you have a HER2 positive early breast cancer, have a multidisciplinary tumor board and decide what you have to do. The general schematic of things are if the patient has a T1 disease with no clinically enlarged lymph node, the patient should undergo surgery. And if then on pathological examination there are node positive disease, you add pertuzumab to trastuzumab based regime for a total of 18 cycles. If the nodes remain negative, that is it's P and 0, trastuzumab and paclitaxel are the usual therapies that you do use. If you have a high tumor burden, if you have a more than 2 centimeter tumor or there is a clinical node positivity, you add pertuzumab to your trastuzumab and chemotherapy, followed by which the patient undergoes surgery. And if there is a pathological complete response, you continue pertuzumab and trastuzumab maintenance regimes to a total of 18 cycles. However, if there is still a residual invasive disease in the sample, you start with TDM1 and give it for 14 cycles. Can you have the next slides? So there are lots of issues with the IV infusion of Perjeta and Herceptin. Although it is, yes, well tolerated, but it can present with challenges to the patients and the healthcare system. Number one is the long infusion and observation time, and which leads to congestion at clinics and hospitals. The infusion of pertuzumab is about 30 to 60 months, followed by observation of about 1 hour. And the Herceptin also has an infusion time of 30 to 90 minutes and an observation of 2 to 6 hours. There are challenges in improving the resource utilization. The preparation time is long, requires high resource utilization, which has associated costs. Then there is problem of placement and maintenance of inferic catheters. These infusions are go on for a year in adjuvant settings and indefinitely in the metastatic settings. So you need a good venous access, which increases costs. There are risks of infection, there is risk of thrombosis and discomfort as well. And sometimes there are challenges in getting a venous access in some patients who have poor venous access. So to offset, can you get the next slides? Next slides, Vishal. Yeah, so to offset these side effects, FESCO has been introduced, which is the first formulation of in oncology, which combines the two monoclonal antibodies, pertuzumab and trastuzumab, in one vial of subcutaneous injection. So FESCO contains the same antibodies as approved for IV pertuzumab and trastuzumab, but has a different route of administration. It is formulated with a recombinant human hyaluronidase to allow a subcutaneous administration of higher drug volumes, about 15 ml of loading dose and 10 ml of maintenance. It is ready to use fixed dose combination administered by a simple subcutaneous injection in the thigh over approximately 5 to 8 minutes. Can you have the next slides? So mechanism of action for the fixed dose combination is similar as we have for pertuzumab and trastuzumab. These are two monoclonal antibodies and lead to a combined HER2 blockade at two different sites. However, there is in FESCO, there is also addition of hyaluronidase. It's an endoglycosidase used to increase the dispersion and absorption of the co-administered drugs when administered subcutaneously. So large volume of these drugs can be administered because we have hyaluronidase, increasing the permeability of this drug across the subcutaneous tissue. Can we have the next slides? So there were a couple of studies. First is we have to identify whether this combination is non-inferior to the already existing uh, combinations. So we had the Federica trial, which was a phase 3 non-inferiority study assessing the combination of the fixed dose versus the IV combination. And we had 1:1 randomization, and investigators' choice therapies were given to such patients in the form of either a dose-dense AC or a AC, which was 3 weekly. And then in arm A and arm B, patients were given in arm A, they were given the IV formulations of pertuzumab and Herceptin, along with either paclitaxel or docetaxel. And in arm B, we had the newer subcutaneous version with either paclitaxel or docetaxel combination. And then patient underwent surgery, followed by the same IV or subcutaneous formulations were given till 42 weeks. There were some primary endpoints which were evaluated, and the main primary endpoint was the non-inferiority of cycle 7, pre-dose cycle 8, serum levels, and there were some secondary endpoints as well, which were seeing the concentration trough, the pathological response rates, the IDFS, EFS, and the survival data that we present. Stratification was done based on hormonal receptor status, clinical stage presentation, and the type of chemotherapy. Next slide, Vishal. So, in short, the serum levels after cycle 7, just before cycle 8, were pretty much identical, or rather more, with the subcutaneous version in our patients. The secondary endpoint was the serum levels of Herceptin. They were again, in fact, greater in the subcutaneous versions than in the IV versions. So the level of serum levels of pertuzumab, it exceeded the non-inferiority margin of 0.8, and thus it established that the subcutaneous version was as good as the IV version. Can we have the next slide? So there were other secondary endpoints as well. The pathological complete responses were identical, 65.8%. And because these are fixed dose combinations, we are always wary whether they will work in obese patients or not. So in underweight patients, there was some disparity, probably because of very less number of patients. N equal to 3 doesn't give you much confidence that the results are adequate. However, our major concern was whether the fixed dose combination is inferior in the obese and overweight population. This was refuted in the results. The rates of PCR were almost equal in overweight and obese patients with the subcutaneous variety as well. Can you have the next slides? So whether the IV, the fixed dose combination was safe with respect to the IV combination. So pretty much identical rates of nausea, diarrhea, anemia, asthenia, and alopecia with the subcutaneous combinations as well as the IV combinations. Can we have the next slides? Yeah, so the incidence of diarrhea, neutropenia, and cardiac dysfunction, which are class specific to these anti-HER2 therapy drugs, were also similar in the IV and subcutaneous versions. So the efficacy as well as the side effect profile of the subcutaneous fixed dose combination was seen to be almost similar to the ones that were conventionally used in the IV forms. Can you use the next slides? So thus, the fixed dose combination of pertuzumab and Herceptin was non-inferior to the IV formulation based on cycle 7, pre-dose cycle 8 concentrations. The PCR rates were identical in both the arms, and the safety profile was also seen to be comparable. Can you have the next slides? Then there was this another study, Francesca, which was a phase 2 design assessing how the patients prefer. Do they prefer a subcutaneous version or do they prefer an IV version? So 160 patients were taken, randomized into initial IV or subcutaneous versions. And then the patients who received IV were crossed over to the subcutaneous, and the patients who received subcutaneous were then crossed over for IV versions for 3 more cycles. And then patients were asked whether they want to continue with the IV or the subcutaneous version. And the primary objective rate was patients' preference of the fixed dose combination. There were some secondary objectives as well. They were the health-related quality of life, the perception on time, resources during each cycle, the crossover period, how the safety profile and the tolerability. Let's see what the results show. Can we have the next slide? Yeah. So all things considered, when asked what patients preferred, 93% of the patient, which indicates a fairly strong majority, patient preferred a fixed dose pertuzumab Herceptin combination as compared to only like 13% favoring the IV formulations. The main reasons given for this preference of subcutaneous version were, number one, less time in the clinic, 42% less time, and they are more comfortable with the subcutaneous administration. 87% of patients thus chose to continue with the fixed dose combinations. Can you have the next slide? Next slide, Vishal. Yeah. So more patients were very satisfied or satisfied with the fixed dose subcutaneous combination, 88% versus 68% in the IV drug formulations. So patients had more time to talk to their healthcare professionals. There was more time for the healthcare professional to have counseling sessions with their patients because they were not now worried about the IV infusions in such cases. Can we have the next slides? So Francisca study showed us that majority of healthcare providers felt safe from switching from IV to the subcutaneous, and they showed that it also reduced time. The drug preparation time was reduced, as well as the injection time was also reduced. Can you have the next slides? And thus, 85% of the patients preferred the fixed dose combination versus 14% the IV combination. Again, the main time was less time in the clinic, more comfortable administration, and patients were very satisfied to satisfied, and most patients indicated that the treatment had no impact in the amount of time they had to talk to their person. Healthcare perception also changed with the IC. There were marked time savings and requiring fewer resources as compared to the IV formulations. And the safety was, and the safety analysis showed that they were well tolerated and no new safety signals were observed. Can you have the next slide?
So sorry to interrupt you. Please conclude your talk in next 2 minutes.
Okay. So there was another time and motion study. Can we have the next slides? How much time do we save in the similar lines as the previous trial? And just evaluating the time that and the resource utilization that happens with the subcutaneous version. Can we have the next slides? So a mean time decrease of almost 30 minutes with the use of the subcutaneous versions, as well as time taken by the healthcare providers were also considerably reduced. Just telling us that how easily the subcutaneous versions can be given and their impact in the resource poor setting. Like, can we have the next slide? Can we have the next slide? I'll just quickly share with you. Next slide, please. Next slide. Next slide. Yeah. So a recent white paper showing the real-world analysis also showed the same thing. Everybody in the healthcare sector, whether it is pharmacist, the oncologist, the healthcare economist, or the patients showed, and everybody realized that using a subcutaneous version was better as compared to the IV versions. Can we have the next slide? Yeah, one Indian study from Pune showed that the use of FESCO was efficacious, and the satisfaction among HER2 positive patients was also there in the subcutaneous version. Can we have the next slide? Yeah, so around 27 patients they had taken in this setting. Can you have the next slides? Next slide, please. Yeah. So good pathological complete responses in the patients. Next slide, please. Yeah, 92% safety ratings with the use of FESCO, and increased rates of time saving, less pain, less side effects, reduced hospital visits. Everything that was desirable to the patients was there with these submitted studies. Can you have the next slides? So FESCO provides benefit in cost, time, and reduction of the patient and the healthcare provider burden. It has a short administration time, 5 to 8 minutes. There's an observation period, which is very less as compared to the IV versions. FESCO has less invasive administration versus the IV. IV needs 2 separate infusions. Fixed dose combination may help reduce the dosing errors, reduce drug wastage, and increase bioavailability, and increase the availability of nursing and staff for other tasks. Reduced time required also has the potential to reduce strain and infusion at the infusion centers, and no new safety signals have been seen when you switch from the IV to the subcutaneous version or vice versa. Can you have the next slide? Yeah. Thank you so much for this talk. Thank you to the organizers. Over to you, Dr. Priyanshu.
Thank you, Dr. Rajat. I think in the interest of time, we can move forward.
Thank you so much, sir. So, for our last talk, I would like to invite Dr. Ketan Dang, is consultant medical oncology from Paras Hospital. So, this session is sponsored by Novartis.
You guys need to update your CVs. Dr. Ketan is in Fortis.
Good evening, everybody, and thank you, Dr. Priyanshu, for this valuable opportunity.
Thank you, sir.
Dr. Priyanshu has an excellent sense of humor, and he should be, and the team should take note of it, whatever sir said. So thank you, and now, first of all, I'll share my slides, and then we will start the presentation and discussion. Are my slides visible?
Yes, sir.
Yeah.
Okay. So we will discuss this exciting topic, that is the evolving evidence for the multiverse of hormone receptor positive, HER2 negative advanced breast cancer patients. So what it means, what the topic means is that within this so-called subset of hormone receptor positive, HER2 negative advanced breast cancer, there are several mini universes that are hidden. And now we are having the luxury of multiple CDK4 inhibitors, 3 molecules, and also I would say NHER2 also in this space in the HER2 low setting. So we have to take a call that which molecule will suit best for our patients, depending on the various subsets, whether they are liver mets with multiple metastasis, aggressive disease, elderly, or bone metastasis only disease, or other special subsets. So that's all that we will discuss in this topic, and that will help decide the clinicians to take a call on which drug is best suited for their patients. So these are the key considerations when you are considering treatment in the first line in this setting. For the patient, the most important is quality of life and their survival. Then the disease characteristics, as we discussed, and then the response to what the prior therapies have been given to the patient. We can see here that the ESMO guidelines have provided this flow diagram for the treatment, for the guidance of treatment of these patients. And we can see the position of CDK4 inhibitors. They lie just on top. And they are sometimes even as important as chemotherapy, as we traditionally used to believe, even when the organs of the patients are likely to fail imminently, that is, patient is in visceral crisis. Even then, they have found their way, as we will discuss. And thereafter, on progression, the guidelines recommend various biomarker testings and then various other agents like everolimus, exemestane, PIK3CA agents, germline, BRCA, and all, they have been discussed. So this slide highlights the importance, the top slot of this set of CDK4/6 inhibitors. So they are the current standard of care for hormone receptor positive advanced breast cancer, that is HER2 negative, including HER2 low, and
in the first line, we have this PFS evidence. Mona Lisa 2 trial, that is ribociclib with letrozole, Paloma is palbociclib, and Monarch is edema. We can see clearly in this statistical diagram that all of these agents have given excellent PFS results. Notably, Mona Lisa, ribociclib, and edema, at the study cutoff, the PFS benefit was, median PFS was not reached. Such good benefit was there in the terms of progression-free survival. Coming to overall survival, we can see here there is one clear winner, and the other two agents, palbociclib, did not show, it failed to show any benefit. Even abemaciclib, we can see the numerically, the OS was much higher, 66.8 months versus 53.6 months. But unfortunately, statistically, it was not very highly significant. So here the clear winner came out to be ribociclib. Coming to the toxicity, we know that abemaciclib does not cause as much bone marrow suppression as the other two agents, that is palbociclib and ribociclib. So neutropenia is less of a concern with abemaciclib, whereas the Western literature says, and some Indian patients also experience more of diarrhea with abemaciclib, which is quite less with palbociclib and ribociclib. We all have a lot of experience with palbociclib and ribociclib, and the clinicians are well versed with managing their toxicity. As far as QT prolongation is concerned, this is a specific rare toxicity with ribociclib, which requires careful ECG monitoring, especially initially. Coming to the quality of life data for these, from the 3 clinical trials, it has been noted that ribociclib not only maintained the quality of life as good as palbociclib and abemaciclib, but it had an additional advantage that we can see here was the delay in the occurrence of pain. So via controlling the pain also, it had a better effect on the quality of life compared to abema and palbociclib. And in fact, abemaciclib had an adverse effect on the quality of life due to severe diarrhea, especially more so in the Western patients than we see in the Asian patients. So the current standard of care and the trials that have shaped the guidelines because of this previous data we mentioned, ribociclib along with aromatase inhibitor sits on top as category 1. And abema and ribo presently sit in category 2A. And we all know that category 1 is based upon not only high level of evidence, and there is uniform consensus that this intervention is the best among them, but category 2A is no less. It is also a uniform NCCN consensus that this intervention is appropriate. We can see in this table that ribociclib has 2 phase 3 trials, Mona Lisa 2 and 7, that led to a conclusive overall survival benefit that made ribociclib shine as category 1 as of now. But this does not imply that in your individual patient, this is the only drug that is to be used, that is the best. No, every clinician has to take an individualized decision based on their unique patient's characteristics. So it is just a suggestion. It is not a conclusion that one is best. So what is the preclinical evidence that gives an edge to ribociclib? So there are 3 main factors that give an edge to ribociclib. One, it is highly selective CDK4/6 inhibitor with less of off-target dose-limiting toxicities. This is also same with abemaciclib. Then there is 8-fold difference in the activity of CDK4 inhibition versus CDK6 inhibition. That leads to more G1 phase arrest for the tumor cells. So this has been compared with palbociclib. Not only this, abema also has a good amount of difference, but that is 5.5-fold versus 8-fold of ribociclib. Apart from that, ribociclib achieves high levels of exposure in the plasma versus other CDK4 inhibitors. In fact, abema achieves higher levels in the CNS, but the efficacy is still, we will discuss there in the next point. So because of this preclinical evidence, it has been noted that ribociclib gave consistent OS benefit across all the studies and not only maintained the QOL, it also improved, and also in the time to deterioration of pain, that was also improved. So coming to this multiverse, so we'll discuss this choosing of CDK4 inhibitor in the various mini universes, that is bone only mets, elderly patients, liver mets, visceral mets, CNS mets, multiple sites, clinically aggressive disease, and what to do in ET resistance, one by one. So coming to patients with bone only metastasis, we have data from exploratory analysis of Mona Lisa 2, which showed that the median OS with ribo plus ET versus ET alone, the hazard ratio for overall survival was superior, 0.78, 72.6% versus 56.4%. So even with bone only metastasis, the median OS was as long as 6 years, which is naturally expected in bone only disease, but it was a good number of years, 6 years median overall survival with bone only disease, which gives ribo the edge over others. Then whatever the age group of the patients, whether 65 to 75 elderly or even more elderly, age 75 or more, the median OS observed was more than 5 years when ribo plus ET was used. This is again a pooled analysis of the Mona Lisa group of 2, 3, and 4, 7 trials. So the median time to chemotherapy in elderly patients, the more the elderly, we are more reluctant to use chemotherapy. And so the median time to use of chemotherapy was efficiently delayed by ribociclib to as long as more than 3 years, even the higher elderly patients, that is more than 75 years. Coming to liver mets, again the data from pooled analysis of Mona Lisa group of trials is favorable, with a median OS of 39.6 months versus 35.4 months, a good hazard ratio with decent confidence intervals, that is 0.71, implying 29% relative reduction in the risk of death. Coming to visceral metastasis, again similar data, hazard ratio of 0.78, 22% reduction. Coming to CNS metastasis, pharmacokinetically, if we see abemaciclib has more CNS levels than ribo, but ribo also has sufficient levels to cause CDK4 and 6 inhibition in the CNS. But unfortunately, we don't have direct randomized evidence from the clinical trials because most of them excluded patients with CNS mets. Regarding the Mona Lisa group of trials, only 8 patients with stable CNS metastasis were included, so the data was not enough. Paloma, the patients developed CNS mets while on treatment, but as such, they were not meant to study. And Monarch clearly excluded the CNS metastasis patients. What data we have from abemaciclib is from a phase 2 study that was non-randomized from the Dana-Farber Institute in the US, from several centers, led by Dana-Farber, and where we noted that it had a very subtle or decent response, but not that great response. Of among the 58 patients, the intracranial overall response rate was just 5.2%, and the secondary endpoint of control clinical benefit rate was just 25%. So, which was not a very impressive, but still it is a decent evidence of efficacy in the CNS, and we need more data on that. So, the data of or the paucity of CNS data is complemented by the complement study, which is a phase 3B real world study of 51 patients with CNS metastasis. So we'll see what the complement study says. So it was a real world study with difficult to treat patients, not the strict criteria of the trial population. It was a real world practice. And the CNS mets was one subgroup, just like other subgroups like prior chemo, poor ECOG PS2 patients, visceral mets. So 51 patients were studied. It was a diverse population. So what the study showed? This study showed that patients with CNS met had a trend toward longer time to progression versus the overall population. We can see here from the Kaplan-Meier curves, the median time to progression was 27.1 months in the overall population. But in patients with CNS metastasis, this median time to progression was not reached at the study cutoff, so which is a valuable input. So patients with CNS mets had a trend towards longer time to progression versus the overall population, which was as such difficult to treat in the real world practice. Now coming again to the multiple metastatic sites, our source of data is the pooled analysis of the three Mona Lisa trials. Coming to overall survival in this subset of patients, it was 49 months versus 40 months, hazard ratio 0.73 with good confidence intervals, implying 27% elective reduction in the risk of death in patients with multiple metastatic sites. Now coming to the traditional view held by the oncologists that in case of an aggressive, clinically aggressive, impending organ function threatened or visceral crisis, the traditional view was that chemo is the savior. So this study broke that myth. This was the right choice study, which included patients with clinically aggressive, hormone receptor positive, HER2 negative, advanced breast cancer patients. Here, surprisingly, the PFS was simply doubled from 12.3 months with combination chemotherapy to 24 months with ribociclib. The hazard ratio was too good, 0.54, p-value of 0.0007. Coming to the other parameters of the right choice trial, so they were non-inferior. This trial, in fact, was a superiority trial where the primary endpoint PFS was very well met. And the other outcomes, ORR and TTR, time to treatment response, they were non-inferior to chemotherapy. So this is again a practice-changing update that in patients with visceral crisis also, clinicians can use ribociclib without fear. And one thing I want to add was the time to response. Even the median time to response was great. We can see here in the table 4.9 versus 3.2. So the time to response, don't worry about that also. That is well taken care of with ribociclib versus chemo. So this is a post hoc analysis of the trial, which interestingly shows that these parameters were much more effective in Asian versus non-Asian patients. So this might help in guiding treatment at the ethnicity level to some extent. But this is a post hoc analysis, not the planned one. This is just a suggestion. So as per the consensus from the right choice, its results reinforce the place of endocrine therapy plus CDK4 inhibitor combination as the standard of care for first line of therapy for the majority of patients, including those with clinically aggressive disease. Although this trial was performed only in pre or perimenopausal, but we can apply it to postmenopausal as we have always done. So coming to ET resistance. So various trials have usually defined ET resistance in the neoadjuvant or the adjuvant setting as a relapse occurring less than or equal to 24 months of the endocrine therapy. And in case of advanced therapy, the patient should have progressed within 6 months of the first line endocrine therapy. So that is how the Mona Lisa and the Monarch trials have defined endocrine resistance. And here we can see that with regards to endocrine resistance, palbociclib has not done well. Whereas Avima and Ribo, they have fared quite well. And the benefit in OS benefit in ET was not in the same range across the various CDK trials. Palbo here was the clear lagger, whereas the other two did well. In ET resistance, we have already seen that even with abemaciclib in heavily pre-treated patients, even monotherapy, we have seen efficacy of abema monotherapy. So whether it is riborabema, ET resistance is less of an issue with them. So the key takeaways from this presentation are, while choosing ribociclib, ease. It makes life easier for your patient with this subset. Ease in not worrying whether it will be effective in a low burden or a high burden patient. Not worrying whether it is a visceral crisis, although the patient need much more monitoring. So we have ease in explaining that this is the only drug till now which has proven overall survival benefit. This is easy to explain to the patient. And the titrating is also easy, and 200 tablets per day or 200 tablets mg per day or 1 per day, they're easily available. So the titrating as per the toxicity is quite easy, and a vast volume of clinical experience is accumulating already. So, and also it maintains the quality of life for our patients. So apart from that, we also have now the multiverse is further strengthened with HER2 low concept and with the advent of trastuzumab deruxtecan. This multiverse is further made more complex, and we usually prefer it once there is failure of CDK4 inhibitors. So that's all. Thank you.
Thank you, Dr. Ketan.
Welcome, sir.
And I think we have finished on time, just probably 5 minutes late. So I'd like to thank everybody who's participated and listened to us patiently over the span of 2 days. And I think we'll be concluding now. Over to the tech team.
So thank you so much, sir. So I would like to thank everyone for joining this 2 days academic feast. So we will meet again in future. So thank you so much.
Good night. Thank you, Dr.
Good
Priyanshu.
night.
Thank you,
Thank you,
everyone.
sir.
Can we close this session?
Yes, please.